You are welcome, colleagues, participants, presenters, to this meeting. This, I believe, is going to be a very interesting meeting. And in some respects, I thought that this is the most important meeting at this World Health Summit, because vaccines are extremely important in this pandemic. If we can get vaccines given to everybody, uh, I think this world may be much more peaceful than what it is. So a discussion of vaccines and how to ensure that there's vaccine equity in the world is absolutely important. Vaccines, science has given us COVID vaccines, and that is something that we have to be extremely grateful for. As we all know, the history of vaccines, usually developing vaccines takes many years before a vaccine is introduced to be given to human beings. But in this case, within a period of 1 year, there were vaccines that could be introduced to populations. And not just one vaccine, but as we see and as the world moves on, several vaccines are now available. So we have to celebrate the fact that from science, we've been able to advance this far in a short period of time in order to address this pandemic, which has really been like no other in the world. It's 100 years since a similar pandemic was experienced globally. But I think in terms of impact, the COVID-19 pandemic is going to stand out alone in its category. Yesterday, I watched on Uganda television, one of our television network, with the vaccine having been introduced, the second batch of vaccines introduced from the COVAX facility, and they started vaccination yesterday. My goodness, my heart sank very low when I saw people scrambling and fighting and raising their voices over the fact that they couldn't get a vaccine because there's a vaccine shortage. Under the circumstances, what can we do? And of course, Uganda is not alone in this situation. Many people, millions of people in the low and middle income countries have not yet had opportunity to get their first dose of a COVID vaccine. And yet other countries elsewhere are in a much better place with vaccines given to many people. So there are these kind of issues around the world, and one may attribute this kind of scenario to market failure and lack of solidarity in the world. There have been deals, as I'm sure we will hear later. There have been bilateral deals between countries, between governments and vaccine manufacturers, bypassing the COVID facility which was introduced. And yet that facility was meant to actually ensure that there is vaccine equity. With those few remarks, let's get started with our speakers. And we will have Dr. John Mary Moka Kimweni, who is a Roman Catholic priest holding a PhD in bioethics. He's an ethicist. He's currently director at the Institute of Ethics, Uganda Matters University in Uganda. But he has also been a great contributor to the Uganda National Immunization Technical Advisory Group, and he's also an active member of the COVAX working group in Uganda. At this point, let me call upon Dr. John Mary Kamweri, and he can say a little more about himself so that he can situate his presentation within the context behind him. So you're welcome, John Mary.
Greetings to the organizers, the participants.
But sorry, maybe before you start, John, so about this, let me encourage the participants to post if they have any question or comment, they can post them in the chat box, and I hope we'll be able Moses can help us to actually keep track of what comes in the chat box, and we will discuss later after the presentation. Yes, John Mary, please continue.
Greetings to the organizers and the participants. Thank you very much for giving me the opportunity to participate in this discourse on a very, very challenging and very complicated topic, COVID-19 vaccine equity. I would like to use this chance to let you know that we are in solidarity with those who are sick, those who have lost loved ones, and let us all support one another and be in unity and solidarity with one another, as also we pray for one another. My doctoral research at Duquesne University was in the area of ethics of pandemics. And so the topic I'm going to talk about concerns the ethical considerations in the vaccine, especially issues of equity. Let me share my slides, and then we can pick it from there. COVID-19 vaccine equity, we are going to look at ethical challenges. When we talk about equity, it arises in the context of disparities. A pandemic outbreak creates a situation whereby there is scarcity of health resources and a lot of challenges in other areas such as economic and social. And those challenges create a problem for all of us. And in terms of when we are sick, death also creates those kind of problems for us. And therefore, health equity, we can define it as the absence of systematic disparity in health between groups with different levels of social advantage and disadvantage. For example, pandemic occurs, or scarcity of resources occurs in the context where in society we have disparity between the rich and the poor, the status, those who are of high prestige and those who are not. And therefore, in the distribution of resources, there can arise situations of injustice or discrimination. And therefore, so we can define health inequity as systematic disparity in health that puts already socially disadvantaged people. Most of those disadvantaged, we can say the poor, sometimes the female disadvantaged, those with the disabilities, the sick, the children. Usually they have reduced autonomy and decreased capabilities. And sometimes they may not be able to, others control what they need, what they have to get. And in the context of vaccine equity, the WHO has already set the tone. And the key assumption is that when all people globally could benefit from safe and effective COVID-19 vaccines in a timely and equitable access to vaccines, beginning with those at high risk of serious disease and death. And why should all people have access to vaccine? Because it reduces COVID transmission, and also we are increasingly observing that it prevents progress to severe disease in some cases, and that's one of the justifications for that. Now, when we look at the World Health definition of health, it is in terms of well-being, and that well-being goes beyond biomedical considerations to social and economic and all areas, and that's what we have seen that during this pandemic outbreak, economic and social functionings are also part of the challenges that we are facing, and they place burdens on people. And in the context of that, we begin to ask questions about what is right and what is wrong, what ought to be done and what ought not to be done. When we begin to ask questions like that, we are in the area of ethics, and equity, vaccine equity, is in that area. And there are three related, there are a number of related concepts to vaccine equity. One is human well-being, the other one is equal respect, the other one is global equity, another one is equitable allocation and access, reciprocity, and trust. When we talk about human well-being, the purpose why vaccines are given is we have seen that it reduces transmission, and it helps us to be able not only from a physiological point of view, but for society to function economically and socially. And that encompasses the definition of well-being as we see it in the WHO constitutions and also in the Human Rights Charter. And the other concept that is related to that is vulnerability. Vulnerability, as I said, they are those groups that are disadvantaged, and they have increased susceptibility in conditions of social disparities. So, for example, when we have during this outbreak, we find that the poor are so disadvantaged. They are not only struck by the disease, but their lack of resources has put them also in a challenge to feed their families and all that kind of stuff. So that is where ethics comes in. Human well-being as a concept associated to our management of COVID and equity means that we need to promote and protect health and safety of populations. And the idea here is to mitigate morbidity and mortality. We can't ensure human well-being unless we do that. And the objective is to reduce death and disease burdens from COVID-19, and also reduce societal and economic disruptions, and also protect the continuing functioning of essential services, including health and health services. So we see that the more we vaccinate people, the more we are able to bring this situation to control. What would be our moral obligations? What do we ought to do, and how? When we are talking about well-being, we must ensure timely vaccine development through adherence to global regulatory harmonization and standardization, that is scientific rigor, in vaccine development to improve speed, flexibility, and efficacy. And these are very, very important criteria for that. Two, ensure there are timely and equitable mechanisms for accessing vaccines. Things like policy frameworks, infrastructure, and coordination, and that kind of other related concepts. On the global or international level, there have been a lot of effort to collaborate and create a kind of global solidarity in response. There was that collaboration and creation of Global Solidarity Fund in May 2020, which also resulted in the COVAX facility, global vaccine initiative to ensure lower income countries are not left out in the effective management of pandemic threats. And we have seen this, that we could easily have been left out. Like in Uganda now, at least about maybe 3% have been vaccinated. Sure, we should be higher than that, but it is also because of the COVAX facility and those partners that have helped us to do that. On the regional level, the African Union and partners have also established a platform for or established COVAX African Vaccine Acquisition Task Team, which is called AVAT. And but they also actions that are not consistent with well-being. While these partners are doing everything they can to ensure that we have vaccines, there are those who are doing vaccines hoarding. And vaccine hoarding, I don't have to mention countries, this is common knowledge. It is not ethical. First of all, it denies others who have opportunity to save their lives in a timely manner. It denies them that opportunity. So because of the delays and for the vaccines that are needed, there is also rigid intellectual property. Rigid intellectual property has also caused a lot of problem with how can we accelerate vaccine manufacturing. And recently, our president, the president of Uganda, talked about issues of intellectual property. They create obstacles to speed the vaccine production. Another thing which is ethically challenging is national export restrictions, so that when nations, and we know that some nations have put restriction on export of vaccines, and this creates shortages, especially in countries that are low income. And these are ethical issues that needs to be addressed. Of course, on the local issues of corruption become obstacles. When vaccines come and you hear that some of them have ended up in private facilities where it becomes a challenge. How did they get there? The other concept we talked about related to equity is equal respect. When we say that the Universal Human Rights Declaration talks of the dignity of all people, equal, inalienable, and because of that dignity, we are one people. We therefore should promote and protect the dignity of all persons. And therefore, if we avail vaccines to all people, it is just the right thing to do. It's the right thing to do in a timely manner. The objective of that is to treat the interest of all individuals and groups with equal considerations as we allocate and prioritize setting decisions. They are being taken and implemented so that the interest of all people are taken into consideration. The other one is to offer a meaningful opportunity to be vaccinated to all individuals and groups who qualify under prioritization criteria. And that would mean equal respect. What is our obligation? What should we do? We should create communication channels, platforms for dialogue with individuals and groups. And we should set prioritization criteria based on ethical considerations to ensure trust and legitimacy. Already the World Health Organization Strategic Advisory Group of Experts on Immunization have already given us some, produced some frameworks to help us achieve this. There is the value framework for allocation and prioritization of COVID-19 vaccination, and then the roadmap for prioritizing population groups for vaccination against the COVID-19, and there are others. And also UNESCO has the World Commission on Ethics of Scientific Knowledge and Technology commenced an International Bioethics Committee that have focused on the issue of especially generally ethical issues, but also vaccine. There is the statement on COVID-19 ethical consideration for global perspective, and then UNESCO's Ethics Commission that calls for global vaccine equity and solidarity. And this one emphasizes that vaccines are a public good. When it is called a public good, it's for the benefit of all. No one has a monopoly over it. And if WHO also has been emphasizing the same concept that vaccines are a public good. On the regional level, the African Union has responded by creating implementation guide for COVID-19 vaccine in Africa. And on the national level, Uganda has the National Uganda Task Force on COVID-19 to address the issues we talked about, and the Uganda National Immunization Technical Group, UNITAG, and also a lot of other initiatives from the Ministry of Health and other partners, whom I'm not able to mention here. They are responsible for, the ministry is responsible for the plan, which they call COVID-19 Preparedness and the Response Plan 2020 to 2021. Now, what are the challenges when it comes to the issue of respect, equal respect? The digital age. The issue is that in the digital age, some social media companies, they are indifferent to the false and potentially harmful information about vaccines. And countries should sit down and really see what needs to be done. This is unethical. Secondly, vaccine skepticism and the spreading of vaccine conspiracy theories. These don't respect others because there are many people probably who are internet illiterate, and when they are told about this kind of things, they just believe them. And absence of COVID-19 policies and guidance in some countries. As of recent, even in East Africa, we had a control somehow, and there was that skepticism about whether COVID really exists. And that does not respect the people. And when you look at the human rights strategy, government has a duty. Governments have a duty to ensure adequate standards of living. This is a challenge if they are not there. Another challenge here is inadequate engagement of stakeholders. Of course, there is a lot being done, especially like in Uganda, but I think we need to be more participatory. We need to include in more of the groups and people that are facing the challenges, stakeholders, especially how do we engage religious leaders, how do we engage cultural leaders to be part of it. We have associations, civil society, how do we get the civil society into play? These are all issues that probably needs to be addressed now because of the magnitude of not only the biophysical issues, issues of social functioning, economic functioning. So we need to widen the gap of the space for engagement. The other issue is equitable allocation and access to vaccines. The idea here is treating all people with equal respect and concern, since all have equal dignity, worth, and value. The objective is to mitigate barriers such as cost and insurance to equitably access through established allocation and prioritization criteria at state, local, and practical levels, and to maximize benefit of vaccines by granting equal opportunity for vaccination to all individuals and across different social demographic groups in the populations, and also reduce negative societal impact due to the transmission of COVID-19 through ensuring continuity of social and economic functioning. Our moral obligation here is what we ought to do is deploy limited supply equitably and transparently across different social demographic groups using pre-established evidence-based criteria for prioritization. 2, treat the interest of all individuals and groups with equal consideration as allocation and priority setting decisions are being made and implemented. Actions that are not consistent with well-being in this regard are one, or some of those we have seen: vaccine hoarding, legality, intellectual property, national export restrictions, and political interference. Political interference has become a big problem. It is unfortunate that the outbreak came when many countries had reached their cycle of elections, and we had people had to figure out, do we need campaigns, do we need, and then you found that the momentum that in many countries that have been built to observe standard operation procedures like wearing masks, physical distancing, during political campaigns, and they tended to be ignored. And so it is not a surprise that in many countries that had that there's a resurgence of COVID. There's no data, there's no data that is available that it is true like that, but we can assume that that could be one of the causes. On national level, the corruption and political interference. There's another aspect of equity, and that is reciprocity. We should honor obligations of giving back fitting and proportionate returns to those who bear significant additional risks and burdens of COVID response to the benefit of society. For example, healthcare providers, doctors, nurses, they put their life on line to try to protect the populations. And unless we acknowledge that and we give them back as an issue of equity, it doesn't make sense. We should secure the safety of frontline healthcare providers to enable greater protection of the health of populations. And following the framework that WHO provided, in Uganda, I think they prioritized the healthcare providers first with vaccine when availability and access, because if we save them, we save ourselves. So application of this principle is reciprocity. Take as first priority the vaccination of frontline healthcare providers. Two, provide adequate protection kits to the healthcare providers to reduce risks of infection. Actually, I don't know how I could describe it. How could we expect them to carry out their duties when some of them don't have the kits? They lack even in some areas, of course. Some may even lack things like simple things that could protect them. And so this should be a priority before we consider other things. Just conclusively, equity builds trust. Significant engagement with relevant stakeholders for transparency, accountability, and unbiased processes. This is important. Once we engage them, they build that kind of trust. They see that transparency, that accountability. But if information, and also engaging them in a manner that they can be able to meaningfully participate, just maybe talking to them over media, television, may not be the only way to engage them. Vaccine information and data sharing with those to be affected. Yeah, we see a lot of vaccine misinformation, even among people who are highly educated. It is surprising when somebody tells you that, well, I might be vaccinated and then I die. It's shocking. This is lack of proper vaccine data sharing and information. So if we share that, we will build trust. Demonstrate that vaccine selection is based on internationally sound scientific knowledge and practice. And we need to find ways to do this more effectively. The social media some on the social media are beating the professionals. No matter how much we communicate, they communicate falsehood, and many people believe them. Lastly, make decisions and common responses based on appropriate representation and shared ethical values. If we don't understand groups' dynamics, for example, in Uganda here, we have like a border group association. If we don't understand their beliefs, their dynamics, it is very difficult to be able to tell them anything that from a professional point of view, that they are not able to feel we are together. So those shared values, group identities, we need to understand them, and the common beliefs, those are part of here. Most of what I've said has already been said in different platforms and by different people. For example, I've drawn most of it from the World Health Organization's value prioritization of COVID vaccine, the ethics of it, and also other sources. So this below are the references where we can get this. I would like to thank you very much, and I know the next presenters will be able to bring everything down to reality. I've given the overall general framework of ethics of COVID-19 vaccine equity. Thank you very much. Appreciate it.
Thank you very much, Dr. John Mary Moka. That was an extensive review of the ethics around vaccine equity. For the participants, please keep your questions to the end, but you can post some in the chat. And when we come to discuss, as you know, with the system, you can raise hands or post in the chat system. Let's go on to the next presentation, and that will be given by no other than Dr. Jonas Tejan. His last name is very long, Wardama.
It's okay, Prof.
Dr. Wadamariam serves as the WHO country representative in Uganda. Although he is an Ethiopian national, he has been around the continent and beyond in many different capacities. He holds a doctorate in medicine. He has over 30 years of experience in general medicine, disaster management, project development, donor relations at different technical and managerial levels. His international experience includes working with Africa Humanitarian Action in Rwanda from 94 to 95. He was in WHO Geneva from 99 to 2005. He was the WHO Southeastern Asia Regional Office for 4 years. He was in WHO India for another 3 years. He was a representative in the Democratic People's Republic of Korea 2011 to 2013. He was a representative in Thailand for 2 to 3 years. And before being reassigned to Uganda, he served as a planning officer at the WHO regional office for Southeast Asia in New Delhi, India from 2016 and 2018. He will be talking to us this afternoon regarding the role played by WHO in Uganda's preparedness to prevent, detect, and respond to the pandemic. He might modify the topic a little bit as you hear from him. You are welcome, Dr. Jonas Wadamariam.
Thank you, Prof. I think that was another topic which I gave yesterday. This topic where I will focus would be on vaccine equity as an overarching issue, and especially focusing on progress to ensure equitable vaccine access. For a start, this is the outline of my presentation. But to go to the major point, why do we need vaccine equity? Because especially in this pandemic, initially we will have a limited amount of supplies. and when there is scarcity, there is a need to have clarity on how to allocate. And basically, it's not like COVID presents us a different challenge. And part of it is that all global economies are affected. So that relation where one could be generous and the other one just the recipient is not anymore an issue, because for the supply, everybody is trying to get hold of it. And I think that led to WHO looking into how to ensure that vaccine equity is there. And this includes from all the way from research on vaccines to the supplies. And as the earlier speaker mentioned, we used our independent strategic advisory group to help us in chartering a roadmap for prioritization so that there could be equity, and based on the epidemiology and world situation that vaccine should be distributed. That is what was the idea behind the COVAX. The COVAX facility is part of what we call the ACT Accelerator initiative by the WHO and partners. And in the COVAX facility, there are 3 agencies which lead it. And this is WHO, CP, and Gavi, with UNICEF being a partner. And this brought in more than 180 countries together and trying to agree on how to proceed. And the COVAX facility was able to accelerate the timeline by investing the money collected from partners and asking researchers to develop the vaccine, as well as expanding manufacturing capacity. And also, there was agreement with some of the suppliers to start producing the vaccine before even the vaccine is licensed, so that we can save time. So the goal is basically that vaccines should be shared equally, equitably rather, and there is a fair allocation based on science, and that it should be fairly distributed, and there is a value and prioritization agreed prior to even before the first vaccines came. Now we have, it was the SAG, the Strategic Advisory Group of Experts on Immunization, also gave us, as the earlier speaker mentioned, a clear guidance on how to prioritize among populations as well. So up to now, the COVAX facility was able to provide vaccine to more than 100 countries, but also the other countries which are middle-income countries are also part of this initiative, because they will benefit from the negotiated access to the vaccines. And the aim was to provide 2 billion doses, literally at least 1 billion of the world population to receive by the end of this year. And the equitable distribution to be based on the population, how vulnerable it is, and also the epidemiological realities. But there is another thing which we don't emphasize more equally. The COVAX facility also aims to ensure that this effort does not disrupt or undermine the routine vaccination or essential health services. There are 2 kinds of prioritization. The first priority and the first phase of it where we are in is to vaccinate at least 20% of the population of each country in the first round. And then after that, the COVAX facility could facilitate countries buying This is what was the aim. So in the first 20%, the emphasis should be for health workers, for older populations, and those who have serious medical conditions. After that, we can look into the economy and elsewhere. But this framework has a challenge. Although there is a clear indication of how it should be targeted, as the Prof has already said, we see that countries do not necessarily follow this. On this transparency, the COVAX facility also tries to look into a specific group of vulnerable people like asylum seekers, humanitarian workers, and refugees to be given a special group so that they are not falling between the cracks. So the first vaccine procurement was done in early this year, and the first COVAX supply was delivered on 24th of February to Ghana. And on March already, the first allocation, the first round of allocation was started being distributed in more countries. And the third round allocation was also made in April. By 31st of May, the COVAX facility has distributed 76 million only. And when you look at it, although by that time we would have expected 160 million, we are still lagging behind in this by about 80 million. That is a challenge for Africa, which is only receiving less than 5% of its requirement. Because as you can see here, in the first wave, Africa has a doubling time of 35 days. That doubling time decreased to 28 days in the second wave, which probably Uganda missed. We only had one wave. But the current wave, which is in Africa, is showing even a faster doubling time and is still climbing, because here we see in the last 3 weeks, we see over 20% of week by week increase of cases. And that is even more worrying when we project the data. Unless there is a real effort to ensure the African population is vaccinated, we could face about 500,000 people dying by October in the African continent. And here you see that the agreement with the manufacturers was to have about 15 million, this is for Africa, about 15 million per month. And by June, that would have increased to 23 million. And we only received the first three, the March, April, and May consignment. We haven't, as Africa as a continent, has not benefited from June and July supplies because either countries have refused exporting, like India having its own challenges, or other countries are buying and, as already expressed, keeping a large stock of vaccine, which should, if the COVAX facilities and there was a fair distribution, Africa could have benefited from. And we expect a fourth supply to be fulfilled by September. And that is a big challenge. The current criteria we use for prioritization, even in this allocation, is looking into case and fatality among 100 per population of the last 4 weeks. And here I brought one of the solutions thought is sharing doses. For example, here we see that the various government has committed between 500,000 to 1 billion doses between now and the end of the year. And some of them are listed. And I have taken an example of a recent contribution or a recent dose sharing by France, where it will be distributed based on the epidemiological factors to each country. And the current dose for Uganda was distributed accordingly. And the next supply would be from
We've lost you. Jonas, we have lost you.
That proposal was presented at the World Trade Organization, which functions if everybody agrees only, and that proposition failed. And now there is already a negotiation on various aspects of that patent waiving, and time is of essence. And all of us have to put pressure on our governments to look into that patent waiver, because that was the mechanism used to save a lot of AIDS patients, and we have to use it so that countries could be self-sufficient and produce themselves. The second option looked and is starting to bear fruit is a transfer of technology. The first of such transfer of technology, a technology hub, was launched on 21st June in South Africa, where WHO and COVAX partners, the South African Consortium, and Africa CDC agreed for a transfer of mRNA technology to South Africa, so that the continent has a certain level of freedom or a certain level of sustainable technology in the continent. The more we produce vaccines, the more kind of alternate vaccines are there, the sooner we will control this pandemic. What worries most of us and keeps us awake every night is that will the virus change and make all our investment null and void, which means all these investments of billions of dollars could be challenged if the virus changes or mutates, which is a challenge, and which we can only prevent if we really take this vaccine equity truly and implement it so that the globe could be protected. Yes, the COVAX initiative is ambitious. It aims to equity in vaccines, irrespective of income of the country, but we have seen the high-income countries have already bought a bulk of it, even beyond their needs. And there are also bilateral deals, some politically motivated to get favors, but others are also trying to get supplies. But this is in a way bad, because it will not serve the global good. Because if we prevent it everywhere, we can beat this disease. Otherwise, we still risk this virus beating us. There are some good initiatives. We think that the private sector and other stakeholders should consider contributing to the COVAX facility or bilaterally, so that operational research, new vaccines, new ways of cost-saving sustainability could be looked into. There is a need to look into how to save on the operational costs, logistics, and so forth. But also multilateral funding from IMF, World Bank, and so forth would be useful. But we also have to look into that the developed world is not swamped, and its sustainable financing is killed by high loans from this bank. And we have to look into a new ways and ensuring that efficient delivery of all vaccines, but especially now it's urgent so that we can save the world. Thank you.
Thank you very much, Dr. Waterman. This is a very good expose of where the world is, and especially the COVAX facility. I'm sure we'll get back to that during the discussions. Just now.
Thank you, Prof. Just call
to
me Jonas, please. It's easier.
Okay. Let's go to the third presentation. And our next speaker is Professor David Serwada, Professor of Public Health at Makerere University School of Public Health. He is a fellow of the U.S. National Academy of Medicine, as well as tours the World Academy of Sciences. Dr. Serwada has participated in 2 pandemics, like, probably a few other people. The HIV/AIDS pandemic, which has been raging on for more than 30 years in Uganda and globally, and now, of course, COVID. Professor Serwada will go on to give us his presentation, and I will not give you the title because I might get it wrong if he made some changes at the last minute. Professor Serwada, you are welcome. David?
Thank you very much. Do you see my screen?
Yes, please.
Yes?
Yes.
Do you see my screen?
Yes, we see it.
You see my screen? Yes, Prof, we can see it. Okay. Thank you very much, Chair. I don't know on my screen the title. It's actually COVID-19 equity, or actually more correctly, the inequity. So oh God, I'm trying to add, okay, no, wait. The outline of my presentation is really going to look at, I think the previous 2 speakers have really done a very good job of really describing inequity, and Jonas has done a good job of what is in place to really reduce the inequity. My presentation is really going to focus on what is the reality. What does inequity look like, actually, ranging from Africa as a whole, but specifically to Uganda in particular. So, and then we shall look at the consequences of this inequity. So I think, as others have said, inequity is a broad overarching theme in this meeting. And I will start off by really, I don't know how many pronunciations the WHO director has made on the consequences of inequity, but he has given some very remarkable quotes since January this year, as the vaccines have started to be rolled out, the consequences of inequity onto this epidemic. And I think that has to be reminded to everybody that this epidemic and the availability of vaccines to make an impact on this epidemic will really not be really controlled in the world until everybody has access, eligible group have access to the vaccine. Now, let me start by giving you the current situation as it states, as it stands in Africa. So far, we have about 5.1 million cumulative cases in Africa, which really represents about 3% of the global cases. And admittedly, the data from Africa is fairly a bit hazy and a bit limited, but I think this is the best case scenario that we do have. And we are contributing thus far about 3.5% of the global death. We are not as high as you would see probably in Brazil, and as you currently see in India, or as we certainly saw in North America, or in the US. but there's nothing to prevent us getting there. I think the recent pictures from India have really shown that every population is very susceptible to this epidemic. At the moment, many countries in Africa, about 50% of the countries in Africa have gone through their second wave, and about a quarter of the countries are really now in their third wave. And what we have seen is that each wave seems to be much more deadly in terms of its case fatality rate. And the third wave, as seen by actually other parts of the world, has really shifted the social demographics of who is actually infected, and we are getting much younger people. Now, as Jonas has pointed out, there is a likelihood that each phase is going to become much more severe and probably, widen the age range in which it affects people, which basically speaks to the fact that really prevention is extremely going to become very critical as we move on. When you look at the distribution of the vaccine coverage in Africa, at the moment, compared to the rest of the country, I think you can see that Africa, the greener the shades, the higher the coverage per 100 people, per 100,000 people. So you can see that of the 2.6 billion vaccinations done so far, only 43%, which is 1.6%, is actually in Africa. And we have a tenfold difference in terms of the people that have been vaccinated in Africa compared to the rest of the region. So Africa stands at 2.4 per 100 persons, and yet the rest of the world, by and large, is around 2.3. So that is what inequity looks like in reality. Specifically, when you go to look at Uganda, we can see that we are in the midst of a third wave, which is quite, in terms of, you can see that when you look at the first and second, the third wave is really steep up, and certainly it's involving many more people. We already see that Uganda is at a cumulative cases of about 1,364 deaths. And, we are maxed out on this, on the admission rate. So we are currently running completely out of capacity, meaning that if there was a fourth wave, or if new variants come around, creating much more severe disease, we are yet to see, if nothing is really drastically done, we are yet to see a much more severe epidemic as we move forward. And this is what lack of vaccination looks like. When you look at the last second wave and the third, we see that cases went really way down. And if we had access to a huge amount of vaccines, that was a great opportunity for us to probably make an impact on the third wave. And I have a feeling that we shall be seeing these swings up and down. And that is where really the lost opportunity is. Now, if you look at specifically on Uganda, what are our needs? I'm gonna, the next few graphs, slides are going to really show the difference between our needs and what is our pipeline supply. Meaning that really within the country, this lack of vaccines are going to be extremely very critical. So Uganda government has estimated that the total eligible population is all individuals around above 18. That is our ultimate aim. Which is around about 22 million people, which times 2 roughly gives you about 44 million doses. That is ultimately what we need to do. We have to have 44 jabs to have 100% coverage, and that is where the golden target is. But we have stratified these needs in as the previous speakers quite correctly pointed out, into people who have high risk exposure and have high risk, subsequently high risk mortality. These are the health workers,
These are the security personnel, the teachers, and the vulnerable population, elderly, and those with pre-existing conditions. So we have tried to stratify that. Next slide will show you, since we got these vaccines, the first bunch of vaccine, which was around 964,000, how far we have gone in vaccinating these various categories, especially the high-risk categories. And you can see we range from 50% in health workers to about only 3.7% in people with people with comorbidity. So even in health workers, there's a very huge gap. This translates to really only about 1.6% on the first dose and only less than 0.5% for people who have had second dose. For comparison, UK has 80% already finished the first dose, and about 60% of their total eligible population already trying to, finish their 60% finishing their second dose. So you can see that there's such a huge disparity that we can see. Not only that, even within the country, these are when you look at the right side, those are the proportion of doses administered against doses issued. You can see even the availability and the doses issued. The darker the region in the country, on the map, the higher the number of people vaccinated. And you can see there's going to be, and there is, regional disparity, not only on the distribution, but also on the uptake of these vaccines. Now, when we look at the pipeline for Uganda, I think number 1 and number 2, we have already got it. But when you look at number 3, 4, 5, that is the sort of pipeline that we seem to see coming along with expected dates that cannot be quite guaranteed. But still, optimistically, by the end of the year, we are really looking at about, on the average, about 10 million doses. Remember, we need a total of at least 44 million doses for everybody to have a first and second jab. So even at the best case scenario, given all other conditions being stable, we shall still be short by the end of this year. And yet, the rate at which we are getting new variants, which are creating a lot of anxiety and completely changing the dynamics of the spread of the disease and its impact, is really going unabated. Now, very quickly, listeners, I borrowed this slide from Campos and Motors, which really shows gives an socio-ecological model of vaccine inequity. There are many places, there are many points in which vaccine inequity can come around in terms of creating it within the country. I'm now talking within a particular country or a particular region. But I think I'll really emphasize one point that has really been of a great surprise. To some extent, the extent of which it has really thrown us off our curve. That is the vaccine hesitant. Not only are we were very surprised by the fact that not only did we receive very few vaccines, a little under 1 million, but the uptake was very low. So we are trying to reduce the spread of the disease. There is little we have, but yet the uptake was not very high as we had expected. And there are various reasons. This was even among health workers. And one of the factors that has been driving, in part, this hesitance has been the social media. I think Dr. John Mary talked a lot about it on social media and how it is affecting vaccine rollout, but it has a huge impact in terms of creating a vaccine inequity within the country, despite the availability of even very few vaccines. And that is something that we really need to look at. Now, this framework, I really liked. I borrowed it from the Journal of Epidemiology, basically showing a potential And my point here, I'm going to really concentrate on the lower part of this vaccine, which is basically potentially creating a potential trap. So you have the COVID epidemic creating inequities, but the inequities really can generate, actually fuel the epidemic. You see, vaccine inequity is going to lead into emergencies of variants, and this will increase COVID epidemics. But it will also have socioeconomic impact, particularly on education, and also generate poverty. But all those are also going to generate, actually, eventually, a bad epidemic, which will eventually create increase in equity. This is what I call the inequity trap, which is really a danger for us moving forward. As the Minister of Health pointed out, this clip on NBC a few months ago, if any country thinks that after vaccinating its population they are safe, it's not true. It's a lie, because we will also be. It's not only a local trap, say in a region, say in a country like Uganda, or a region like East Africa. It's also a worldwide trap. In other words, one region cannot vaccinate completely, another region is not. It will just generate problems for everybody. So, Chair, in summary, I think the structural health disparities have always been there, to be sure, within the regions and countries and within countries. But COVID-19 has increased the awareness of this disparity, and it will likely increase this disparity. And there is a danger that inequality, it will create an inequality trap. Lack of vaccine leading to severe epidemic, which in turn will exacerbate inequality. So this word inequality is still going to be with us a lot, and any efforts to mitigate it are going to be extremely very important moving forward. My worry, though, is that Africa's first and second COVID epidemic wasn't really very bad. Africa had been spared the first bad epidemic swing, which was mainly in Europe and North America. And then the second one came. But by the time the second one came, or the third, we already had vaccines available. And if this availability had been available to many countries, I know there's a short supply, but some countries have more than they need. This is where the real problem is. If they could be able to share that, it could actually spare Africa, which is the most vulnerable in terms of its health system structure, to a much bigger surges moving forward. So this is a really call to arms, the big agency, to avoid this trap creating a much bigger consequences on health in Africa. Thank you very much, Chair.
Thank you very much, David, for that very clear presentation, and ending up with the inequity trap that we may end up with. So participants, it's time to have a very lively discussion about what has been presented and even what has not been presented, but relevant to the vaccine inequity. In the chat, I see two questions, and we can get started with those, but please keep them coming. The first one is, what are some of the ways these online falsehoods could be timely stopped? And I think the questioner is referring to those that come through mainly the social media, but also others which may be spread by word of mouth. Dr. John Mary, you would like to respond to that. And after him, Dr. Jonas can immediately come in. There is a question that are other countries doing vaccine sharing using the same mechanism France used, or what has the WHO advised on how to share doses? And there's another question that with lack of vaccines, what is the fate of countries like Tanzania, which are just starting to acquire vaccines? Will they get some chance? John Mary, falsehoods.
Uh, Thank you very much. That is Moses. I think Moses, yes. Uh, Thank you for asking this question. In this digital age, it is going to be very difficult to say we can completely stop online falsehood, but we can reduce its impact and also minimize the level at which it is being saturated. The idea is that these people play on people's fear. COVID creates issues of safety, and among the general population, the professionals and the ordinary people like me, we assess risk very differently. When we tell people that the vaccination maybe has an efficacy maybe rate of this, and there could be a risk, a small risk, maybe 0.5. The ordinary people might be, I would say, I may be one of those who are going to be in that risk. So for us, as we look at percentages and we say, okay, the benefits outweigh the risks, somebody might say, I will be one of those in those risks. So fear becomes a problem, and it is understandable because nobody has all the answers in an outbreak. So there are two things we need to do. Information. We need to counter. We need to counter this false information at all levels, internationally and even locally, regionally. We need to invest.
Sorry, John Mary, somebody has got two devices and we are getting the echoes. Please continue.
Okay, all right. I think it is still there.
No.
It's with Professor Suarata. You have to.
Okay, all right.
Yeah, sorry.
Yeah, we need to counter information in a very timely manner. That means we need to invest funds and human resource at every level. For example, internationally, there should be funds set aside for people, experts, who can easily detect and deter this information or respond to this information immediately. They could be in every organization, even locally, like at the ministry, for example, Ministry of Health in Uganda. We need to have that kind of group of people who immediately detect this falsehood and send out information to correct information. And that is one of the way we can deal with that. Secondly, we need also to those multinational companies, social media, internet, there should be some kind of advocacy to persuade them to really rein on those people who send false information. We saw an example whereby they started maybe the accounts of those kind of people, they are closed or they are suspended, and this needs to be done regularly. There should be really effort to do that. That's one of the punitive measures that needs to be taken. Thirdly, I would think that we need to reach out. Let me say this with an example. Recently, the government of Uganda, they are going to give some funds, relief to the vulnerable people. Then the following day or 2 days after, we began to see on the social media kind of information, false information, advising people to fill in their information online, and they will get it to them in 24 hours and process their funds. And the day after, I saw a press release posted and alerting people that this is not true. This is false. I hope this kind of thing can be done very often, and we invest in it, and also train personnel to deal with that. Those are some of the things that I would think could help us to be able to deal with this issue of falsehood. Thank you.
Thank you very much for that response. Let's go on to Jonas.
Thank you, Prof. And thank you, Esther, for the questions. The first question about vaccine sharing is WHO and COVAX partners. We promote that governments should share through the COVAX facility because it's neutral. It has a criteria where it will allocate based on epidemiology and the need. So that is what France did. That's what Sweden did. That's what Norway did. But there are other countries which do also bilateral donation. For example, China is donating 300,000 for Uganda, and India donated 100,000 earlier. That also helps, but we would prefer if it is through a joint mechanism and where the allocation has no, which may or may not have other motives, economical or political support. But I think that's the best one. Now, your second question about Tanzania is, I think part of the benefit of having a fair, equitable distribution and a mechanism to allocate according to that would enable countries which are introducing the vaccine late to also be getting the vaccine they need and to catch up. So I would hope with not only just agreeing on the vaccine, but also bringing it into the country and implementing it fast would enable Tanzania to catch up with the lost time. I'll stop there.
Thank you. There are three other questions. There's a comment about South Africa, and that's a comment. The other question is from Charles Semgabo. What do we imagine will be the impact of the EU digital COVID certificate denial to individuals that received AstraZeneca vaccine that was made from the Serum Institute in India? This call it decision has just been issued on vaccine hesitancy, especially that it's what we have access to here in Africa. Anybody can come in who wishes to address that question. The questioner, though, specifically directs it to Jonas. Then the next one. Yes, you want to go ahead with that?
Yeah, I think it's unfortunate, but also, as you know, any licensing is not only for the chemical, but also, or for the vaccine, is also for the manufacturing plant. It's unfortunate that the Serum Institute of India has not been assessed by the European Medical Agency. We are promoting, actually the European Medical Agency has made it clear that they endorse WHO's EUL listing, but there was a caveat at the end of that saying each countries would have the right to issue their own certificate. So it makes it difficult. We are following through our European Regional Office on this issue because it has raised a lot of concern scientifically, politically, as well as on implementation elsewhere. So we expect some progress to be made in the negotiation between the COVAX partners and the European Union. This has happened only a few days, so we expect some progress to happen soon.
Thank you. Thank you very much. Then we have Saddam here saying, are all the current available vaccine types still under emergency use authorization? And if yes, when can they be fully licensed? Because this could be one of the ways or one of the causes of vaccine hesitancy. Again, for you, Jonas, and maybe you could explain a little bit more about the emergency use authorization so that we are on the same page with the listeners.
Yes, you see that all the vaccines, first of all, are under emergency use authorization. The reason is normally it takes a long time data gathering before regulatory authorities accept a vaccine and give a license. That is why on emergency situations, which we did, for example, in Ebola, and now in COVID, and to a certain extent in upcoming other vaccines or drugs, is to weigh the benefit and the uncertainty with the available data we have. For example, we used to say vaccine produced AstraZeneca or the other vaccines have a shelf life of 6 months. But that is because we only have data for 6 months. And then as time goes and we see that the vaccines are still viable, we extend that time. So it's an issue of gathering sufficient data to fulfill the legal requirements for licensing. And because of that, also the manufacturers are hesitant to agree, because of the legal implications, to issue the vaccine without getting such a listing. So that is what we try to do. And this also helps to convince manufacturers to ensure they start producing even before licensing formalities are fully agreed. But Prof, you could also address that. On the issue of South Africa, which is also brought here, the reason the RNMA hub is established in South Africa is because the technology and other things were conducive. But there is effort to look into other hubs in Africa, and some of the countries are showing interest to establish vaccine production capacity. You cannot just get up and say that I'll produce a vaccine tomorrow, or because I put the factory, it happens, because it is a very complex thing. And it doesn't only mean you have one factory. There are a number of other biochemical industries which has to support the vaccine production. So it so happened that it's conducive in South Africa, and that's why it was done. But we expect soon other countries will join it. Thank you.
Thank you very much for that, Jonas. If I may add, those two questions, or a question and a comment, take me back to the opening session of this regional World Health Summit, where the chief host, His Excellency, the President of Uganda, really emphasized the point that manufacturing vaccines in country would be one way to overcome or to minimize the issue of vaccine inequity. Because if the vaccines are being produced in the country, then you are not at ransom because of what is going on in the market elsewhere. But the question that therefore comes to mind is that as the country puts in place, does the science to produce a vaccine, it must be paying attention to the issue of eventually the vaccine being approved in different places if it is to be used elsewhere. And so that is a different process that really needs to go on concurrently, because as the science is done and therefore setting up a manufacturing plant happens, one has to be cognizant of what the requirements are. As you have said, for AstraZeneca, that it's not only licensing the chemistry, but also the plant itself being inspected and so on. And so that needs to happen. Otherwise, one meets an obstacle that was not expected. Just like when you read about the AstraZeneca issue, the professors who started the research in Oxford, they were thinking like scientists, and they're just doing stuff, you know, to produce a vaccine. And they were not paying too much attention on how to market, how to bring a product to market. That the way they went about issues is different from the way that a vaccine company would have gone about business, because of their knowledge of what needs to be in place and so forth. Let's go to the next question. The second wave, people have started associating the vaccine to death. I think they are what Roger Sekawira means is that they are saying if you get the vaccine, you are likely to die. Should therefore one vaccinate after being tested for COVID-19? The way the second part of the issue is phrased gives the impression you need to answer the first part first and see whether the second part holds water or not, although it could be addressed separately. So anybody can weigh in on this, any of the panelists who would like to have a shot at it? This is one of the things that are, yes, sorry, who is that? Go ahead.
Chair. Chair, I wanted to say that this question of apparent observation that people who have been tested are coming down with the disease is in part, yes, there have been cases of people who have been, even doubly vaccinated, 2 shots, who have come down with the disease, and some have actually died and some have not. I think the public is not, first of all, the public is not seeing the denominator, i.e., of all the people who have been vaccinated and got infected, how many have been saved from having severe disease or actually not even dying at all? So that is the picture that is missing. And probably there are quite a number of people who have been vaccinated, somehow got this disease, but have been that has prevented them from having severe disease and from actually dying. However, it is important to point out that actually the vaccine, whether it's AstraZeneca or Pfizer, is not 100% efficacious, just like any other vaccine. Polio or measles, or they are not 100, meaning that it does not prevent disease in 100% of the people. So the endpoints for the AstraZeneca, which we are using here in Uganda, is really prevention of severe disease. And that prevention is up to about 80%, meaning that there's quite a number of people, up to 20% also, who actually may actually get the disease and have severe disease. So it's a question of probabilities, and I think that message needs to be communicated, and we discussed this yesterday during our vaccine advisory committee meeting, that just like polio, people get vaccinated, not necessarily completely get prevented from having polio. So I think that's very important. The second part of the question is that people who have got the disease, should they still be vaccinated? The current guidelines suggest that it still recommends. We do know that there's various degree of immunity after infection to COVID. Some people get mild symptoms of COVID, and some get very severe disease. But there's really very little correlation between the production of antibodies. So you can have some, your immune response, particularly after mild infection, may not be that strong to be able to prevent you from further attacks, rare as they may. So we still recommend having a vaccine after you have had, even after you have had a COVID infection. Thank you.
Thank you very much. Let's move on to the next one. Is from Katana Akene, and says tentatively, sharing of vaccines equitably may actually provide a solution to the skyrocketing contractions, but Europe, USA, or China will save their people first and then roll out help to others. And he thinks that what is key is knowledge sharing. Knowledge sharing, how do we share knowledge through joint research and other mechanisms to have an equally spread development of their vaccines to break down monopoly? Oh yes, Jonas is ready to give a shot at this. There's a second part to it, but that first question, the question of intellectual property protection and so forth, was hinted on. What mechanisms are in place to mitigate bias among people brought about by differential or preferential use of vaccines, for instance, Pfizer, AstraZeneca, in relation to efficacy and even side effects? Jonas?
I think the effort we are trying to do in both pushing for patent waivers as well as technological hubs is to fill that gap of knowledge. And I think both will help in the countries like African countries to get the manufacturing capacity so they could be self-sufficient. We should all push for that. But also we should invest in research. The whole issue why most of these drugs are discovered, patented in Europe, North America, or some in China, is because these governments invest a lot on research. And it is important governments have to invest in research and development and developing such infrastructures to be able to produce strategically important medicines and vaccines. I think that's obvious. To your second part of question, honestly speaking, up to now, we have been very comfortable in other vaccines, which are far more less efficient with less efficacy than the COVID vaccines. And we were able to do a major achievements in public health protection of diseases. I think the efficiency we see in all the vaccines which are produced and EU held up to now is sufficient to make a major difference in the survival of the patients and in controlling this pandemic. And my advice is that what is the most important vaccine and what is the best vaccine among all the vaccines we have is the one you get immediately. So it's more important to vaccinate people with whatever vaccine we have as soon as possible and control and stop this pandemic. Over.
Thank you very much, Jonas. So let's go to the next question.
Excuse me. Yeah,
yes,
may I add in?
Please do, please do.
Yes.
Sorry.
On the previous question, I mean, there was that idea that developing countries will first try to save their own people and then maybe think of others later on. Sure, issues of information sharing are very important. Waiver of intellectual property is very important. But hoarding vaccines to the extent that you have even excess is disrespect to life of others. I mean, you are trying to say others are not very important. So if you have excess that you are keeping for people who have not even been infected, I think that could be a problem. Thank you.
Thank you very much. Hoarding. People have lots of vaccines for certain countries, and yet here we are struggling to get the vaccine. As I told you, watching the news last night really sank my heart, because you saw people, whereas there was a lot of hesitance in the past, but now people are waiting, they want to have the vaccine. And so how do we get this vaccine to them when actually other countries have got a lot of that vaccine? What mechanisms should be used? Let's move on to John Rubaihayo. He said he joined late, he apologizes, but if vaccine coverage globally is 2.7, rough 2.6, and Africa's share is only 1.6, is it because COVAX has no funds to procure enough vaccines? Or it is because of what other people have called vaccine appetite, which is rich countries are given preferred treatment? That's an interesting question. Any of our panelists who would like to get started with that? Yeah, if I can start. COVAX facility does not have money of its own, and it depends on resources from different countries. They donate money because COVAX ends up buying the vaccine from the manufacturer. And so if, for example, the United States says it is not going to put money into COVAX to buy the vaccines for our low and middle income countries, then COVAX will not move very far. So it's partly the answer is COVAX does not have the kind of funds that it requires. It has been trying to mobilize, and I don't have figures offhand right now, but it's been trying to mobilize funds, and it has not secured the funds that it requires for to buy the vaccine in the quantities it would like to to distribute to our countries. And then the second part of it, he says, is it that it has no funds to procure? Or is it because of what other people have called vaccine apartheid, where the rich countries are given preferential treatment? The rich countries have gone ahead. In fact, they went ahead when the pandemic started, and they negotiated with companies and made a booking. And by the way, at that point, they didn't know which vaccine was going to work, but they knew that companies were in a drive to make the vaccines. And they went ahead and negotiated with those companies, making a booking to get certain quantities of vaccines. And as by that time, even COVAX facility was partly not there, but even when it was existing, these countries were negotiating with the manufacturers. And so the manufacturers reserved vaccines for those countries. So COVAX may not access vaccines from company X because the production there for the next several months has already been booked by countries X, Y, and Z. And so that contributes to COVAX failure or inability to secure the vaccines that are required by Uganda, Rwanda, Kenya, Tanzania, and so forth. But Jonas, you may want to, I see you want to come in here. Please comment.
Thank you. I just wanted to add things. It's very complex. We have countries who have gone ahead early last year to already procure from multiple companies. Even some of the vaccines are not yet produced. And some of them have secured doses 3, 4, 5 times their population. So those have clogged the production. On top of that, when India went into its third wave, export was banned of these vaccines. So all this have a factor. On the other hand, I mean, we can't also be blaming some of the big countries, because at the same time, they are the ones who have funded COVAX to make this 1 billion or 2 billion doses available. Now it's more than the financing, it's the production itself, which is a problem, and what countries have blocked. So that's what we are trying to do, trying to negotiate with governments to provide this and provide it to the COVAX as soon as possible. For example, the US have announced what it wants to give. The European Union has done that. I think we have to press, and some of you are from those countries, we have to press our governments to also fulfill their commitment. First of all, we went into these difficulties because governments do not fulfill their commitments of relying on a fair distribution. But it's not late. We have to press more for that to happen. Thank you.
And in there lies the question of what mechanism should the world have, an effective mechanism, so that when there's agreement on certain issues like solidarity here for vaccines, that is implemented and countries do not sidestep that agreement. Those are all kinds of questions that are associated with this question. There's this anonymous attendee. It's appeared several times. It is said that Africa produces only 1% of the vaccines administered. I think this is not quite correct. Africa produces only 1% of the vaccines administered. Oh, I see. Oh, this is a general question. It is not COVID vaccines, but vaccines in general. I think that's what it is saying. If, in your view, why is Africa lagging behind in terms of producing vaccines? What is it that is lacking? How can we bridge these gaps? And this question, I would encourage if also anybody among the listeners wants to make a contribution, please just raise your hand. So who wants to get a go at this? In general, Africa produces only 1% of vaccines. Why?
Yeah.
Why are we lagging behind?
Yeah, Chair, if I may, I think the statement 1% of the vaccine is correct. Only 1% of the overall vaccines in general. I think the point you made, Chair, that when you produce your own vaccine, you're able to actually determine your own fate is basically very well illustrated by the situation of India and AstraZeneca. India produces its own vaccines, or produced AstraZeneca, and when they had a very serious problem within their country, they were able to determine their needs and say, look, we need more vaccines, we cannot export. So leaving everybody a little bit behind. So I think the question of India has really brought on the forefront the need to actually produce vaccines in Africa. I think that's one way of really reducing inequity on vaccine production. And the answer to that question is very simple. Governments have not put in the infrastructure or invested in the infrastructure that is required to produce those vaccine, even under patent from other groups. So the infrastructure is there. And I think in the case of the COVID vaccine, there's also the issue of the technology transfer that is going to be required at this point in time. There are not that many people who have the technical know-how to actually produce mRNA vaccines, but you start always your vaccine base starts with already established vaccines that are probably not as technically difficult to produce. So you need the infrastructure and you need the technical know-how, which both requires both human and financial investment. That's the simple answer why we cannot produce. So we have been lagging behind all these years in terms of production of vaccine. So it's a call, really a wake-up call to Africa that really, you have to put your fate in your hands. You cannot rely on others to really be, wait for the, donations to be able to manage your own epidemics. I hope this will translate into action by African leader, mainly pushed by the African Union, I hope.
Okay, let's get to Jonas. You seem to want to add something here.
No,
I see your name.
Perfectly all right.
Okay.
I'm perfectly all right. We encourage our governments to invest in strategic pharmaceutical and biological production companies.
Okay. Next one is Esther Nakazi. By the way, we are soon coming to an end. If there are 2 more questions, we will be able to deal with those. So if you have the 2 questions or a question, please post it. Esther Nakazi is asking, in a follow-up to Jonas's answer, we know that Chinese vaccine is underperforming, showing the examples of Shislis and China. should we continue still to use Sinopharm and Sinovac vaccine? This is an interesting question.
Very interesting, actually.
I'm happy it's Jonas answering it.
That's a very difficult one, I agree. And I would ask Professor Nelson to help me with this. Is the fact is that we base, or WHO bases its EUL on the evidence produced. If there is, the vaccines fail after a certain time, we will depend on those evidences being looked at. And in this time of overload of information, the analysis and the conclusion do not come that easily. And our analysis of the data produced to us as WHO for the SAGE was indicating that this vaccine is safe and it protects well. We are still trying to get more evidence on Seychelles and China cases. We also have now Israeli with an increased cases. All those evidences, whether those have to be examined and advice be given. But I still insist that what we are seeing is the immediate effect of protection outweighs even this small number of cases appearing as people who have been vaccinated being found to be positive. One thing we also have to look into, for example, in the last week, the US didn't report deaths among people who have been vaccinated. Those are major issues. People can get sick, but those vaccinated were not among the one who died, or there are only very few cases. So those kind of facts should persuade us to still push forward in vaccinating as many people as soon as possible so that we can come out of this pandemic. Over.
Thank you, Jonas. If I may add to that, let me start by saying people are very quick to jump to conclusions. I've had people in my country saying, oh, my two relatives got the vaccine and one of them became very sick and maybe another one died. Therefore, that vaccine is not effective. There's no point taking that vaccine. That is what I mean by jumping to the conclusions. It's like when it was reported globally that people who took AstraZeneca or Johnson & Johnson, let's deal with AstraZeneca first, that they had thrombosis, clotting in their systems. And some people actually died who had clotting problems. And again, the same quick jump to conclusions. But if we want to be, and that is the way we should be, sorry, there's a truck passing by in my backyard, hence the noise. But it's not, it doesn't serve humanity well if we just keep jumping to conclusions. Yes, it is important to make those observations that yes, the people who got the vaccine ended up getting an infection, a COVID infection, or they fell sick in this way. And the evidence is looked at, as Jonas has said, very, very carefully by experts, not by people who just say, because this has happened, therefore they conclude something else must therefore be the issue. People, the experts sit and really look carefully on the evidence and then come up with a matching conclusion. What happened in Seychelles, for example, yes, people got vaccines, but we need to understand how those who were affected negatively, what was the background to their getting the vaccines, and look at all that data and then come up with conclusion. So that's the way science works well. The last point, just for emphasis, as Jonas has said, vaccines will have their negative side. But when you look at the potential benefit from a vaccine or vaccines, so far, the potential benefits are much more than the negative side of things. And therefore, in a pandemic like this, you will want to argue that having weighed the benefits and risks, it's more important to proceed with a particular vaccine. That is a roundabout way of answering the question. I guess what I'm trying to say, let's not jump to conclusions before experts have looked carefully at the data and made good sense of it. I think this will be the last one from Dan, sharing sharing information about adverse events following vaccination will make it possible to inform about the benefits and risks balance in the context of COVID vaccine. That is absolutely true. Having to follow up those who have been vaccinated and documenting carefully the adverse events will give us a better understanding on the benefits and risks. This may contribute to mitigating vaccine hesitancy and anxiety. As stakeholders actively monitoring COVID-19 vaccine, the short answer is going to be given by Jonas. He has already penned in there. He's trying to type in an answer. Why don't you just speak to the response, Jonas, because time is closing up on us.
Yes, I was more than that. There was one question which I put as answered, which was not answered about patents. I just wanted to comment. I think we should push more on African, the patent waiver. The current stage is that although the first round resolution was voted down, currently there are 4 proposals and there is what we call negotiation on text. So it's not fully closed. So we should promote the patent waiver for COVID vaccines and therapeutics and diagnostics, so that Africa and the rest of the world can produce at a reasonable cost vaccine, these products. As for the AFIs, I think it's important that we share information, and the information, we also accept the information. I think part of the problem we see in the social media generation or in now is that even when the experts explain and clearly answer the questions, we see still hesitancy from at least some of the people not to accept the facts. And all AEFIs or adverse effects are not necessarily linked to the vaccine. They could be coincidental, but we tend to stick to the negative aspect of it. And all of us have a role in promoting the right science, the right messages. Thank you.
Thank you very much. And finally, because time is up, Noami Keba is advocating that we should adopt the saying, half a loaf is better than none. Let's get over this pandemic sooner, even if the efficacy is low. Those few protected still make the rest of us safe. And the beauty is that the efficacy so far in all the vaccines that are being which are being used as under emergency authorization, their efficacy is above the minimum recommended by WHO. The minimum is 50%, and all these vaccines are above 50%. Thank you very much, the panelists, and thank you very much, the participants, for a good discussion over the 2 hours. Thank you, presenters, for having taken the trouble to make the presentations. The session is closed.
Thank you for good sharing for you as well, and thank you for moderating us.